saves lives, and so does lung screening. My name is Sean Lear. I'm a physician assistant who works in the thoracic surgery department, and I'm the lead provider of the lung nodule clinic at Newton-Wellesley Hospital. This webinar is hosted by the Newton-Wellesley Hospital Department of Radiology and Thoracic Surgery. It is presented by the Newton-Wellesley Community Health in alignment with the American College of Radiology Pink and Pearl campaign. We'd like to make everybody aware that November is Lung Cancer Awareness Month, and Newton-Wellesley Hospital is again participating in National Lung Cancer Screening Day, which is this Saturday, November 9th. This annual event aims to raise awareness and promote lung cancer screening. The goal is to make lung cancer screening more accessible to patients by offering screenings after hours and on weekends. I'm delighted to present tonight's speakers. Tonight's event will feature 3 presentations, followed by a Q&A session with our expert panel. As we're going through the presentations, please submit all of your questions via the Q&A feature. So let's get started. I'm pleased to introduce our spotlight speakers. First, Dr. Pragya Dang, Section Chief of Breast Imaging at Newton-Wellesley Hospital, Department of Radiology. Next, Dr. Christina Cosentino, Thoracic Surgeon at Newton-Wellesley Hospital, Department of Thoracic Surgery and the Lung Nodule Clinic. And last is Jennifer LaHoy, Environmental Analyst from the Massachusetts Department of Public Health, Bureau of Climate and Environmental Health Indoor Air Quality Program. So first up is Dr. Pragya Dang. Again, she is the Section Chief of Breast Imaging at Newton-Wellesley Hospital, Department of Radiology. She completed a residency in diagnostic radiology at Massachusetts General Hospital in 2014, including a dedicated focused year of training in breast imaging. She also served as chief resident in diagnostic radiology during her residency. She has been practicing as a breast imager since July of 2014, when she first joined as faculty member at Massachusetts General Hospital, and then moved to Brigham and Women's Hospital in September of 2016. She joined Newton-Wellesley Hospital in November of 2019. In her role as section chief, she has built a team of subspecialty breast imagers at Newton-Wellesley Hospital. Her focus has been on improving the timeliness and quality of care and reducing variability in practice. She is a board-certified subspecialty trained diagnostic radiologist. Her clinical practice involves interpreting mammograms, ultrasounds, breast MRI, and performing image-guided breast procedures. She has served on both local and national breast imaging committees and is a member of the Society of Breast Imaging / American College of Radiology Screening Leadership Group. Her interests include appropriate utilization of breast imaging modalities in early detection and diagnosis of breast cancer and improving quality and timeliness of breast care. And with that, we welcome.
Thank you for the introduction, Sean, and I'm so excited to see so many attendees. This is great. And hopefully through this talk, I can share some important facts about breast cancer screening. I designed this talk to answer some of the very commonly encountered questions in our breast clinic. And hopefully with those answers, I can provide you some important facts, as well as remove some of the myths about breast cancer screening. So I wanted to start with this question, which is very common. When we encounter a breast cancer or a suspicious lesion in a woman, the first often I hear, I don't have a family history of breast cancer. How can I get breast cancer? Do I really need screening? What are my odds of getting breast cancer? So I wanted to share that, unfortunately, breast cancer is very common in women. It is the most common cancer in women. And almost 13% women would get breast cancer during their lifetime, which is a 1 in 8 number. And in fact, 1 in 6 of the breast cancers that are diagnosed are in women who are in ages 40 to 49. So unfortunately, breast cancer is common even when you are average risk and do not have a family history of breast cancer. In fact, 3/4 of the cancer actually do occur in women who are average risk with no family history and no high risk factors. The good news is that most of these cancers are curable if detected early. So screening is extremely important because of the incidence and the prevalence of breast cancer. And starting at 40 is important just because there is a pretty high percentage of cancers that occur in women who are 40 to 49 years of age. So the next question I wanted to answer was benefits of screening. What are the benefits? How is screening helpful? And as we all know, mammography saves lives, but I wanted to highlight exactly to what degree. So decades of evidence has shown that mammography reduces breast cancer deaths, and it's in the range of 20 to 49% as we see many studies. In fact, if we look at this graph that is seen here, when mammography screening was introduced in the early 1990s, we can see these breast cancer deaths or breast cancer mortality rate. And after the introduction of mammography, we can sort of see this decline, and it has declined by 42% up until 2019. So it is so clear that mammography screening saves lives and saves lives by a very high percentage. And the other benefit is that, when it detects tumors on screening, when they're not palpable, when somebody cannot feel it, they're usually smaller cancers, and they have a higher chance of cure and require less extensive treatment, requiring lumpectomies instead of mastectomies, and even sometimes not requiring chemotherapy for a large percentage. So it reduces the breast cancer deaths as well as the comorbidities associated with the treatment because it requires less extensive and less aggressive treatment. So, women often come to our clinic and say, I don't feel anything, so how can I have a cancer? But that is the goal of mammography, to detect these tumors that are too small to be felt and hopefully curable at this stage. So the next thing I want to talk about is then when should I start screening and how often should I get screening? Unfortunately, there is so much information and misinformation about there and so many guidelines, which causes so much confusion. But I wanted to highlight the data that are present right now. The most important thing is if you look at the data, all major healthcare groups agree that starting screening at age 40 and performing annual screening saves most lives from breast cancer. And I've highlighted that, this is a busy slide, but if you see the highlighted row, that's what it says. Women starting screening at age 40 and continuing annual screening, it'll reduce your risk of dying from breast cancer by 40%, and approximately 1,200 lives will be saved per 100,000 women screened. These are the other guidelines that exist, and mammography saves lives, but if you do more frequent screening and starting at age 40, as recommended by the College of Radiology, Society of Breast Imaging, it saves most lives from breast cancer. So our recommendation is start at 40 and undergo annual screening mammography. And I just wanted to highlight again, starting at 40 and the importance of 40. Breast cancer is not a trivial issue in women in their 40s. In fact, it's a very important area of health concern. It is the second leading cause of all deaths in this age group women. And in a woman, the odds of getting breast cancer in their 40s sharply rises when you compare 35 to 39 years of age. In fact, women who are age 40 to 44 are twice as likely to get breast cancer compared to women who are in the age range of 35 to 39. 1 in 6 of the breast cancers that we find are found in women who are 40 to 49. And in fact, 1 in 5 breast cancer deaths are women in 40 to 49 years of age. These women are young. They have many, many years of life ahead of them. So if you actually just look at that concept of years of life lost, a third of the years of life lost from breast cancer are in these women who are in their 40s. And in fact, these are the women who get these aggressive cancers and early onset cancer. So, we want to be able to identify and pick these cancers and treat them. Half of the fatal cancers in women are diagnosed before the age of 50. So I cannot emphasize the importance of breast health and starting mammograms at 40 because it is an important health concern and issue in women in their 40s. And then I also want to highlight that if you look at the women in their 40s who are not undergoing screening, 20% of the women who do not undergo screening in their 40s, majority of the cancers that are found in these women, they are dying from breast cancer. So over 70% of women who are dying from breast cancer in their 40s belong to those 20% who are not undergoing screening mammography. And the women who do not undergo screening mammography are also more likely, 3.5 times more likely to get mastectomies, more aggressive treatments, and 2.5 times more likely to get or need chemotherapy. So start at 40 and get mammograms annually to improve your chances of, identifying small cancers and saving your lives from breast cancer to the most. The next thing I wanted to tackle was risks. Every test has its associated risks. And I wanted to talk a little bit more about risks because we often encounter that in our clinic. Women are nervous, they're anxious about mammography, and they worry about the different risks that are unfortunately highlighted in the media. So here are some of the risks. Busy slide, but I'll go over it. This is just a little, graphic that I took from the College of Radiology and Mammography Saves Lives website. But basically, it breaks down when women get screening. So if 100 women get screening, approximately 10 of them will need additional pictures to clarify if we're questioning something on the screening mammogram is real or not real. So those 10% are called false positives, where many of them will have nothing, but a woman is called back. And that causes a lot of anxiety and nervousness around in women, because everyone's thinking they have breast cancer, they have to wait for these additional pictures. Mammography is not a comfortable test. However, evidence has shown that this anxiety is brief and it's alleviated with negative results. So when you get a mammogram, approximately 10 women will be asked to return, but of those 10, 6 will be reassured that their mammograms are normal. And the anxiety associated typically is alleviated once there are negative results. Approximately 2 of the women will be asked to come back in 6 months for additional, follow-up imaging for findings that are probably benign, but we keep a close eye on them. And about 1 to 2 will be recommended to undergo a biopsy. So biopsy is another risk that is associated, because even though it's a minimally invasive procedure, low-risk procedure, only about 25 to 30% of these women will have cancer, and 70% or so will be benign or negative. So yes, these are false positives, but it far outweighs, the benefit of saving your life from breast cancer far outweighs these risks that are associated. These are non-lethal, minimal risks. And the last thing I wanted to touch is radiation. That is always a concern amongst women, but I want to highlight that the radiation associated with mammograms is way below the FDA regulation. In fact, it is equal to the radiation you would receive just, from natural sources of radiation in your background, less than 2 months of background radiation, just living on Earth. If you took a transatlantic flight, you'd probably get more radiation than a mammogram. So the radiation is minuscule and is not significant. And again, I cannot highlight that the benefit of saving your life from screening far outweighs any of these risks, which are unfortunately really highlighted for women in media and causes people bad press for mammography. So the next thing is, who is at a higher risk for developing breast cancer? Do they need more aggressive screening, earlier screening? And how do we identify if I am higher risk for breast cancer? So in this slide, I'm just highlighting some. It's a long list, but I'll talk about some of the factors that can increase your risk for developing breast cancer. These are medical and hereditary factors, such as if you have a family member who has a breast or ovarian cancer, if you have had breast cancer yourself, or you carry certain genetic mutations like BRCA1 and 2, or your family member has a genetic mutation and you're not tested. Other thing is if you've received radiation to your chest for cancer, lymphomas before you're 30 years of age, or you've had prior breast biopsies that have shown atypical lesions, precancerous lesions. Dense breast tissue slightly increases your risk of breast cancer as well. And then other things like obesity, if young age at menarche, you're old when you get your menopause, or you've never had children. These are some of the factors that could increase your risk for developing breast cancer. And there are many factors, not just one, that together contribute to your lifetime risk of developing breast cancer. So basically what I want to highlight is that if you think you have these, risk factors, it's always a good idea to talk to your doctor about your breast cancer risk. And it's recommended at around age 25. especially women if they think they have a family history of breast cancer, ovarian cancer, they're African American, Ashkenazi Jewish descent, they usually have a higher risk of developing breast cancer. So talk to your doctor about your risk. And usually women who have a lifetime risk of greater than 20% when all these factors are combined together may benefit from additional testing for screening. And that is, screening with MRI, sometimes ultrasound, and other modalities that are now developing, such as contrast enhanced mammography. So they may benefit from additional testing and screening earlier than age 40. But these tests I want to highlight are adjunctive screening modalities. They're additive to mammograms. They do not replace mammography. Mammography is the gold standard and the study that has shown to reduce deaths from breast cancer. The problem with these studies is that they would detect more cancers, but they would also detect other findings that are not cancer, so false positives. So they are beneficial in addition to mammography, but only in a certain subset of patients who are at a higher risk for developing breast cancer, greater than 20%. So talk to your doctors about your risk. And if you truly are high risk, then you will benefit from additional screening and starting screening younger than age 40. Then the next question is, when do I stop screening? So, often older guidelines said stop at age 74. But actually, as life expectancy is increasing, the benefits of screening are also increasing in women older than 74 years of age. In fact, if you look at the studies that now exist, they confirm the life-saving benefits of screening in older women older than 75. And as you can see here that I mentioned, women ages 75 to 84, those who have yearly screening mammograms, their chances of dying from breast cancer are reduced by about 65 to 70% when compared to women who are not screened. And of these women, if they're screened every other year, even then their chance of dying from breast cancer is reduced by half when compared to women who are not undergoing screening. So I think when to stop screening now, the guidelines by the College of Radiology say that should not be based on age. It should be an informed decision. You discuss the risks and the benefits, look at your comorbidity, what is your overall health status, and then decide when to stop screening. But basically, we say that if you are able to undergo the biopsies we recommend or the treatment for breast cancer, then you should be able to undergo screening every year still. So lastly, just to summarize, start screening annually at age 40. This is how you'll optimize your chances of reducing your risk from dying from breast cancer or picking small cancers. Make your appointment annually. Decision to stop should not be just based off of age, but other factors such as your health, overall health, and how you can tolerate additional procedures if recommended. Talk to your doctor about your risk. If you think you are higher risk for breast cancer, additional screening, early screening will be beneficial for you. And lastly, make sure you get 3D mammograms. That is the standard of care, especially if you have dense breasts. Thank you so much. And these are some of the resources that are very beneficial and helpful for women. And lastly, if you have any questions, I'll take them at the end.
Thank you so much, Dr. Dang. I think that was very comprehensive and very informative. So ladies, we've got to start in our 40s, and it sounds like we do it annually, pretty much almost indefinitely. So next up, I would like to introduce our second speaker, who is Dr. Christina Cosentino. Dr. Christina Cosentino is a fellowship-trained thoracic surgeon who specializes in all benign and malignant diseases of the chest. Her area of interest include the diagnosis and treatment of lung cancer, mediastinal tumors, tracheal conditions, and esophageal diseases. She has a specific interest in robotic surgery and sees patients at both Mass General Hospital and Newton-Wellesley Hospital. Dr. Cosentino received her BA from Princeton University and her medical degree from Jefferson Medical College. She completed her general surgery residency and cardiothoracic surgery fellowship at Mass General Hospital. During her fellowship, she completed additional oncological surgical training at Memorial Sloan Kettering Cancer Center. Dr. Cosentino has published multiple papers in high-impact journals and has presented at national and international conferences. She holds various leadership positions on academic committees and is invested in educational endeavors to mentor and train the next generation of thoracic surgeons nationally. Her research interests include studying the molecular and genetic pathways that underlie the development of thoracic tumors, innovation in robotic surgery, and the pathophysiology and surgical treatment of subglottic stenosis and other airway disease. Her current research involves studying the molecular and immunologic profiles of early stage lung cancer and the gender differences that exist in the development of thoracic disease. Thank you, Dr. Cristantino.
Hi, everyone. Thank you for that introduction. I apologize. I'm still muted here. All right. It's so nice to have everyone here tonight. I'm excited to talk a little bit about lung cancer screening and what we can hope to learn and educate the community on how we can get more people out for screening. So I'll start with a very simple question: what is lung cancer? As many of you know, our lungs are exposed to pollutants and chemicals and pathogens every day by what you breathe in on an everyday basis. The lung is an amazing organ that really does a phenomenal job of both protecting against infection, clearing bacteria, and has its own self-defense system. But exposures over time can cause damage to cells within the lung tissue. And so when a cancer forms, there's a variety of different types of cancer. You'll most commonly hear non-small cell lung cancer. That's the most common types. And below those are some different histologic subtypes, including adenocarcinoma and squamous cell carcinoma. Adenocarcinoma is the most common. But of that subgroup, it's when the primary lung cells develop a certain number of mutations and develop into a lung cancer, where they grow over the normal cells that are in the lung tissue. And so we'll talk a little bit more about some of the differences in types of cancer. But let's talk a little bit about the scope of the problem generally. So when you look at cancer statistics here and now in 2024, lung cancer is still one of the leading causes of cancer-related death. So it has the highest, when you look at new cases altogether for both men and women of cancer cases, lung for both men and women is up there with prostate and colon cancer in men and breast and colon cancer in women, accounting for about 50% of the new cases per year. And then of those that actually kill patients, lung cancer is a leading cause in both men and women. So, as we mentioned, accounts for 1 in 5 of all cancer deaths. And as a leading cause, most people are diagnosed in about the age of 70, although, as we'll talk about later, there is an increasing number of particularly young women who are being diagnosed with lung cancer as well. And so, over a lifetime, when you look at all comers, we always talk about smoking as the high risk patient population, but about 1 in 16 men and 1 in 17 women will develop lung cancer over their lifetime. The important thing to note about this particular slide is just when you look at the red line here, and you see this arrow at the top, which indicates when lung cancer screening was instituted, which is actually later than a lot of other types of cancers, so 2013. And what that's just telling us that most cancers before that time were diagnosed with, or lung cancers were diagnosed with distant disease, so more advanced stages of disease. And you can see that the 5-year survival for patients with advanced disease for lung cancer is abysmal. It's around 5% or so. And after introducing screening, you can see on this green line here that that's local disease, that we make a much more impactful contribution to both their survival benefit with diagnosing them early. And so that makes you wonder, how do we currently screen patients? So just to briefly mention, this is a very, very important trial, and it's a landmark trial that really created the guidelines for lung cancer screening in 2011. It took patients who compared chest x-rays to CT scans, which is the image on the right, where you can see a lot more detail of the human body with the CT scan. And it compared those over a 3-year period. It found that in patients who underwent CT screening in a high-risk patient population, I'll talk about what those guidelines are. So, patients between the ages of 55 and 75 with a 30-pack year smoking history, that if you got a CT scan, it reduced the mortality rate of patients by 20%, which is really a substantial amount. And what's most important here too, in these small graphs, if you pay attention to the orange, you can see on the right for the CT scans, the patients who underwent screening in that way, it shifted the diagnosis stage to an earlier stage disease. So those patients in the CT scan cohort were diagnosed over 50% with stage 1 disease, which in our realm is most commonly a curable cancer, often with surgery and other modalities as well. So the current guidelines are based on that landmark trial and then other subsequent trials, which have broadened a little bit of the criteria and shown replicated that reduction and actually shown an increase of the mortality benefit. And so the current guidelines are ages 50 to 80 with a 20-pack year smoking history. And that can come in the form if you smoke a pack a day for 20 years or 2 packs a day for 10 years, and are a current smoker or have quit in the past 15 years. That alone accounts for about 20% of the population. So about 50 million people actually are eligible for screening. But as you'll see in this later slide, only about 6% of patients actually undergo screening in the US. And so there often is the question is, we talk about overdiagnosis or invasive testing as secondary cause of screening. And there is a lot of concern about that. But what subsequent studies have done, including the American College of Radiology with their LungRad scoring system, has allowed us to really hone down on the patients' CT scan findings to allow us to really stratify which patients should get next step testing, invasive biopsies or monitoring CT scans over a 6 to 12-month period. And so that allows us with your provider to really try and treat the whole patient and understand where do we intervene in this pathway once we've detected some abnormality on the CT scan. When you look at the country as a whole, I mentioned before, only about 5.8% of eligible Americans are getting screened with those criteria alone. And we're talking about smoking history. If you are listening from Massachusetts and live here, you're lucky because we're of the highest screening rates in the country. It's only about 16%. If you go to Kentucky or the central or south US, you'll find that the screening rates are much lower. Some of those have to do with, and as are the mortality rates in those states as well, unfortunately. And that also has to do with other social habits, smoking, other exposures as well, and then access to screening, which we are very lucky for and worked very hard at in Massachusetts in particular. So we've talked a lot about smoking as sort of a general, the most, when you're looking at a screening test, you want to have the highest population or the highest risk population. So those of you out here listening who have a heavy smoking history, you know what to do in terms of where you fall in those guidelines. But what about the others? We know, and what we're seeing in recent years and subsequent studies is that there's a subpopulation of patients who actually are developing lung cancer without the same exposures. So globally, about 15% of all lung cancers in men and 50% in women are not attributable for smoking. And we're starting to learn more about that. And is it genetics? Is it other environmental exposures we don't know about? We're not sure yet. When you look specifically at gender, women in lung cancer, what you'll see, and is interesting about this graph over, starting from 1975 to about 2015, for men, which is the top line here, the rate of new cases of lung cancer has increased, 14% from 1975 to the 1980s, and then has since decreased by 40%. And the important thing about that is it follows the trends of the smoking epidemic around that time. For women, the rate of new cases increased over 133% among women from the same time period up until 1998 even, and has decreased 16%, but at a much slower and less rate over that time. And so over the last 5 years, the rates in women has decreased from 14% for men and 8% for women. And so we're starting to wonder what is, women socially took on smoking a little bit later on in those certain decades. Are there other secondhand and environmental exposures that we're missing as part of it, and hormonal factors? And we'll talk briefly about that. And then also, why is there not a decrement in their number of lung cancer cases as well? And so it talks about all these risk factors and susceptibility, exposures, genetic predisposition of particular patient, what their particular tumor looks like genetically, which is important for treatment, and we'll talk about that. And then what other biologic hormonal factors are contributing. So in terms of exposures for women, approximately 20% of women diagnosed with lung cancer are lifelong non-smokers. When you look at their genetic mutations, meaning when you look at the tumor and you look at sort of what the makeup is of the mutations, the people who have not smoked look a little bit different than the current or former smokers. And even if you look at non-white populations in Asia, for example, there are other higher incidences of types of mutations, such as an EGFR mutation. It's a driver mutation that we find very commonly in the Asian population and in a non-smoking white, Asian, it does matter, population, and we're seeing that more frequently. Additionally, what we're finding in the CT scans are that in a lot of these patients, you might ask, well, if I don't qualify for screening, how do you discover my lung cancer? There's about 1.5 million nodules per year, or findings at minimum. That's actually old data that is finding its way into our clinics, our thoracic surgeons, our pulmonologists. You had a CT scan for your heart and they find something on your lung and don't know what to do with it. What do we do, and how do we follow that thereafter? And so that's where a lot of patients are being diagnosed these days in what we call an incidental finding. And what you'll see on some of these scans, the younger women are having findings which you call like a GGO, ground glass nodule. About 50% of women are likely to have this type of nodule. It's describing the morphology of the actual lesion in the lung. And 60% of these tumors actually are adenocarcinomas. They tend to be more indolent in their behavior and slow going. And then they often do harbor, when we talk about the genetic mutations, EGFR mutations, but we are studying all of the types of mutations that are coming with some of these early stage cancers. This is just a brief slide that's just to say about the exciting or important and exciting piece that comes along with new targeted therapy. So it's not all dismal. Yes, we are diagnosing a lot of new lung cancers. We're learning a lot about their tumors and how to treat patients. Surgery is a mainstay of early stage lung cancer treatment. But what we're also finding in some of these other studies, that as we learn more about the tumors, there are targets on the tumors that we can treat. Much in the way for breast cancer, people more common with hormone receptor positive breast cancers, and you're treated with a hormone for 5 years. This is an analogy in lung cancer where we find a particular driver mutation that we have a drug that can inhibit it. And so this study, the ADORA trial, showed us that when you give an EGFR inhibitor to patients who have that mutation, after they have resection or lung cancer resection, they live longer, is the sort of punchline here. And so we're learning more about these things. And I think excitingly, survival, even though we are still behind lung cancer screening as compared to our sort of other types of cancers, we're seeing that the 5-year survival rate is increasing steadily, from the 80s to now in the early 2000s, and has increased even at a much faster rate. So we're really making some headway, and that has a lot to do with implementation of screening, and then trying to advocate for increased uptake within the community. So for patients with that history to be screened. And so I'll just end with this slide, which is sort of, we've talked broadly about smokers and then another subpopulation of women and non-smokers. Those who are eligible for screening have a heavy smoking history. But for those of you that find your way into our clinics from incidental findings or having CT scans for other reasons or other family histories, there's a lot to be done, and a lot of good news to follow. So thank you. I don't have any other questions at the end.
Great. Thank you, Dr. Cosentino. I think that's another very informative presentation with a lot of information. So please, if you have some questions, don't hesitate to put them in the Q&A feature. So next up, we have the pleasure to introduce Jennifer LaHoy. She's an environmental analyst from the Massachusetts Department of Public Health, Bureau of Climate and Environmental Health Indoor Air Quality Program. Jennifer's presentation, Radon 101, will provide a clear and easy explanation of radon, why its exposure is harmful, and what you need to know about testing and mitigation. And she's having a little bit of technical difficulties, so we're going to work together. And let me pull her slides up for. Okay.
Hi, can everyone hear me?
Yes.
Oh, hi, this is Jen LaJoy.
Thank you for joining us. Are you able to see your slides?
I am. I'm so sorry, everybody. I have no idea what happened tonight with Zoom, but I'm calling in with my slides right in front of me. So if someone could just help me change them, that would be
Sure.
great. Okay,
Perfect.
so the first slide, are we at Introduction to Radon?
Yes.
Okay, great. Next slide, please.
Okay.
Okay, so a quick synopsis about tonight. I'm an environmental analyst at the Department of Public Health. And one of the issues we're dealing with right now is trying to get the education out about radon. Sorry, I couldn't hear a lot of the earlier presentation, but November is Lung Cancer Awareness Month, and radon is definitely on everyone's mind right now. So that being said, radon is a soil gas. It is tasteless, odorless, colorless, naturally occurring. It's a natural decay product in the ground. And most importantly, probably, it is radioactive. Next slide, please.
Okay.
Okay, so radon does exist in our environment. So like I said before, it's naturally occurring. Radon isn't one of those things where you're either positive or negative for it. There's always going to be some level of radon outside, inside your home. So radon is measured in something we call picocuries. So as you can see on the slide, the average outdoor air radon concentration is 0.4, and that's picocuries per liter. Also on that slide, you can see how radon comes up through the ground. It is a natural decay product of uranium into radium and into radon, which is a gas that comes up into the home. Next slide, please. So the risks from radon, it's an inhalation risk. So you're breathing in the soil gas. The radon decay particles enter your respiratory tract, and the damage occurs when the particles decay. So they can attach themselves to stuff like dust, and it's flying around, and you're breathing, and then it is going onto your lungs. But there is also always some level of radon in your home, and I'll get into that in a bit. Radon is also cumulative. So the risk depends on the two factors here. How much? So what is the level of radon you're dealing with in your home? And how long are you exposed to that level? Next slide, please. Okay, so radon is a known carcinogen and can increase your risk of lung cancer. It is the #1 cause of lung cancer for people who have never smoked, and is the #2 cause of lung cancer overall. And we do obviously find that if you are even a former smoker, that your risk of issues with radon is greater. And next slide, please. Health risks from radon exposure. So according to the EPA, obviously you can see from here this graph, radon is the leading cause of lung cancer and kills an estimated 21,000 Americans each year. Obviously you can see that's a lot more than a couple of other categories on this chart. Okay, next slide, please. Just checking in, does this one say action and mitigation levels?
It does. Yes.
Okay, thank you so much. So as I mentioned before, that radon is measured in something called picocuries. So the Environmental Protection Agency has determined, they've made some recommendations, basically, about action levels in radon. So when you test your home for radon, I'll get into that in a little bit, you're going to want to know the number. And when the number comes in at a 4 or above, the EPA recommends that you install what we call a mitigation system to try to get that level lower. They are also recommending that you consider fixing your home for radon levels between 2 picocuries and 4 picocuries, with the target being less than 2 picocuries. And I will say, just talking with people who have had systems in their home, those numbers can get down quite low, and a lot less than 2 picocuries in a lot of cases. Next slide, please. So what's going on in Massachusetts with radon? As you can see here, a lot of homes above that action level that the EPA has of 4 picocuries per liter, approximately 650,000 homes. And then you can see going down how many above 20, that's 34,000 homes. And the highest radon level we've ever measured in the building, that was us, 1,981 picocuries, which is just staggering. That was actually in a school, and it has been mitigated, and they're doing great right now. We will kind of, what we call ring the bell at 100 picocuries if someone calls us and we've determined that their test results seem legitimate and they're hitting 100, we recommend that they actually vacate their home until they're able to mitigate. Next slide, please. So health risks. Yep, in 2005, the Surgeon General released a National Health Advisory Radon. They recommended testing your home every 2 years, and we still recommend that. Test every time you move, obviously, if you're in a new building. Structural changes or occupy a previously unused level. So if you have a basement and you're not really using it, but you're planning to spend some time down there, we say even if you're going to throw a treadmill down there or use it as a workshop to test that level. Also, if you're doing any construction on your home, plumbing, changing things, insulation, even new heating systems, that can actually introduce more radon into the home, or it can trap more radon. So we do recommend testing if you're doing anything kind of major structurally like that. And then obviously, like I said before, if you're getting the levels of 4 picocuries or above, take the steps to fix your home. That is what we call the mitigation. And next slide, please. Okay, radon sources in a building. Ways that the radon can enter your home. So like I said before, it is a soil gas. It comes up naturally from the ground. There's no way of knowing how much you have unless you test, and I'll get into that in a sec. But everyone at some level, there are certain things that kind of can, what we call, mine it more into your home. And it's just normal things that we do that you can see from this chart of this house. Most of us in New England have basements. They are definitely places where you can have your highest levels of radon because they are in the ground. So cracks in the foundation. Some pumps are a great way for radon to come in. It's just a hole in the ground and, needed, but radon can come up through there. And then anytime we're doing plumbing, we're puncturing that ground and it can kind of bring in some more radon. You will see on this graph here on the right side that there is some radon in well water. There is a recommendation to test your well water if you have private water. It's not that you're ingesting water with the radon, it's that the radon is a gas coming into your home through your water when you're showering, doing stuff like that, and it can add to whatever level is in your home. Next slide, please. Should I test my home? We recommend everyone test your home. Any house that touches the ground, unless you're up on pilings and you do not touch the ground at all, you're probably okay. What your neighbor is getting is not an indication of what you get. Radon is tricky. It moves through the ground. We don't know how much is in there. Soil can make a difference. Some people have a neighbor with a really high level and theirs isn't, or vice versa. We do offer free radon tests at the moment while supplies last. Homeowners who have never tested their home and are not engaged in a real estate transaction can contact us, and I'll give you my contact a little bit later. Next slide, please. Can I test if I rent? Absolutely. You can do it yourself. We can provide the kits. If your landlord doesn't, you can, like I said, do it yourself. You can ask the landlord, or you can call us and we can provide you some kits. Next slide, please. Radon air testing dues. Please test during what we call the heating season, approximately now until March. But it's really kind of weather dependent too. Super warm today. What we call the heating season is when you're running your heat regularly. So maybe wait a little bit till we get deeper in the winter now. Your lowest livable area, or wherever you could spend time, and I know I talked about that a little bit, with your basement, and if you're planning to spend some time. Closed house conditions, that means you close all your doors and windows prior to the test and while you're testing. That is a little picture of the kits that we provide. They're short-term kits, and they go up for 48 hours. And then, like the Surgeon General recommended, we recommend testing every 2 years just to make sure nothing has really changed. Next slide, please. And then the don'ts. Weather events can spike up your levels of radon, winds, lots of rain, stuff like that. We just recommend kind of testing during a calm time period, or you might get some spikes that aren't really indicative of what's going on a normal basis. Same with unseasonably warm temperatures like today. And the best case practice is to not put them in rooms that have running water. So that would be a kitchen, laundry, bathroom, or closets. Obviously, you're not really spending a lot of time in a closet probably. Next slide, please. The summary for the testing, this is important. The test kits are very, very accurate if they're done correctly. So we always encourage people read over the instructions, let us know if you have questions, testing your lowest livable area. And if you're testing in the summer, just you so happen to be, just retest in the winter because your levels can be quite different. Next slide, please. After mitigation, so a mitigation system is installed if you have that 4 picocuries or above. What do? That's great. You obviously retest after the system goes in to make sure that levels went down. But then we also recommend, even if you have a system, that you're still testing every few years just to make sure that the system is keeping up with anything that's going on there. Next slide, please. The resources, our website is pretty good. mass.gov/radon. We have a bunch of fact sheets. We have a lot of information on what is testing, how do you do it, what do you do if your levels are high. We also run a line, and I'll get to that in a second. Next slide, please. We have what we call our radon information line. It's manned every day, Monday through Friday. You can just call us, or you can email us at this email with your name and address, and we will send you out some kits. We might have a few questions for you, and that's only because we're trying to make sure that we're getting the right amount of kits to you and exactly where to place them. New England, we have a lot of old homes. A lot of them are kind of rambling, might have some areas that are built over different foundation types. We just want to make sure everything's covered. And if need be, we can get you out some water kits as well. Next slide, please. And then that should be the Connect with DPH one, I believe I'm on.
Yes.
Yes, thank you. And then just some ways to get in touch with us. And that's really it right now. And I'm definitely open to some questions. I hope everyone could hear me okay.
We could hear you perfectly. That was great. Thank you so much.
Okay, thank you guys so much.
Super informative. I think one thing I didn't realize is that once you have a mitigation system in place, you should continue to test. So we have one in our basement, and I haven't tested since we moved in, so it's good to know. And patients are always surprised.
Absolutely.
Patients are always surprised that radon gas is the second leading cause of lung cancer too. So it's thank you. I'm glad that this was able to work
Yeah.
out. So at this point, I'll
Oh, you're
ask all
welcome.
of our presenters, in addition to Rosanna Morissette, who is our lung cancer screening guru at Newton-Wellesley Hospital. Any questions you have about lung cancer screening, she will definitely be able to answer. So I will start off with, let's see. So this one is for Dr. Dang. What is the average age for starting menses, and what is the average age for menopause? Does Medicare cover mammograms? She had breast cancer.
Great question. I think the average age for starting menses in the US is around 11 to 12 years of age, and menopause is 51 to 52 years. The starting menses is changing over time. And then Medicare does cover mammograms as a part of preventative health services, screening mammograms, and I think it covers Medicare Part B covers 80% of Medicare approved amount for diagnostic mammograms if they are clinically indicated, recommended, or you have a palpable finding. So if they're clinically necessary, it covers that as well.
Great. This question would be for Dr. Cosentino or Rosanna. I smoked a pack a day for 15 years, but quit 31 years ago. I would like to be screened. How can I?
Do you want me to take it, Dr. Dang? Or I'm sorry, Dr. Cosentino.
That's
Do you want
okay.
me to
Yeah,
answer?
sure.
Okay.
Yeah, sure, go for
So the current guidelines right now are for smokers who have quit within 15 years. So at about 14 plus year, 14 and a half years, or anything under 15 years, then you would you would qualify for lung cancer screening. But unfortunately, right now, you would not be covered under the current guidelines if you had quit longer than 14 years. The other suggestion I do have is that people should talk with their healthcare providers or their PCPs to see what other risk factors they may have. And then it's worth your while to perhaps contact your insurance company with that information and ask them to do a predetermination to see if they would make an exception to cover you for screening. Sometimes it works, sometimes it doesn't, but at least it's worth the try. Once you have quit and no longer smoke after 14 years or within 15 years, you're no longer considered in that high risk category, which is what they're screening for. So I hope that helps.
That's great. This one's for Jennifer. Is there any financial aid for radon removal systems?
Yeah, there can be, is kind of the short answer. We encourage people to check with their individual cities and towns. What we're seeing more is that cities and towns are becoming aware of this. And oftentimes the planning department, or if there isn't a planning department in that city or town, if they're a little smaller, the clerk's office or even the building office might have what we call just general funds that can fix homes. And a lot of times they're including mitigation systems under that category. It's very arbitrary. It's probably your best bet is just call your local city or town and ask them. I know I checked with the city that I live in, which is Salem, and they said, yes, they are covered. However, I think it is going to be one of those things where you might have to submit some income verification. Just to give you a ballpark, what we're hearing from our mitigators is that systems are costing about $1,200 to $2,000 for a pretty complicated large one. So we say probably somewhere in the middle, $1,500, $1,600.
Great, thank you. Next, someone said that she had nodules that were found during a CT scan for another issue. Follow-up CT scan was done, and at that point, it indicated that the nodules were not cancerous. And she's wondering, should I have another CT scan in a few years?
I can take that one. So I think it's a great question. If you don't meet the high risk screening guidelines, which it sounds like you don't, you found this was found incidentally, anything that's found should be followed up with at least some subsequent imaging study. And oftentimes that can be done through pulmonologist, your primary care doctor, and our radiologists are excellent and are able to read the comparisons with, and then you are interpreting that information with your provider, like your primary care doctor, and your clinical information about it. So it sounds like, you know, we have no way of knowing for some of these types of nodules whether they are benign or not. And if that was the decision, or that was what was decided based on your follow-up imaging, and you don't meet other criteria for screening, then you really don't need to have there's no indication to have a, you know, in 10 years, all of a sudden you have another follow-up CT. What often ends up happening for patients who are incidentally found to have nodules is that they end up being followed for a while. And that's sort of one of the downsides of when you enter into this, you're not in a high risk category, but you end up being followed, meaning getting a CT scan every year or something like that, because there aren't specific guidelines for us as providers to understand how long we should be following you and for what those nodules might do or not do without, you know, we don't want to go biopsying them and all of this. So the short answer to your question is there's no reason to get another interval scan unless you have a new development or something in your clinical history. But it is a tough thing that most people are end up being followed for a period of time.
Great. And I just want to be respectful of everyone's time. So if we have a little more time for a couple of other questions, I'm happy to do that. But I also, you know, we can answer these questions in an email with all of the additional information. I know I have some questions in here about how can we get like the phone number and contact information for radon testing. So we will send a follow-up email to everyone who's joined with all of that information.
Sure, sounds great. Thank you.
Sure. All right. Well, I want to thank our presenters again. What a great evening. I'm glad that this all worked out. A ton of information about screenings for breast cancer and lung cancer and all of our risks. So thank you again.
Thanks, everyone.
Thank you.
Thank you.